My name is Vera Grupa. I am a medical student from the Leiden University in the Netherlands. Thank you for the opportunity to present our results. I conducted this study during my 6-month research elective at the Royal Adelaide Hospital in Australia. This study is titled Current Practice in Australia and New Zealand for Defunctioning Ileostomy After Rectal Cancer Surgery with Anastomosis, Analysis of the Binational Colorectal Cancer Audit. The authors declared to have no conflict of interest. Colorectal cancer is one of the most prevalent malignancies in the Western world. In Australia, there were more than 16,000 new colorectal cancer diagnoses in 2019. Approximately 1/3 of these are located in the rectum. After neoadjuvant therapy, the majority of these patients require a rectal resection, mostly a low anterior resection with the formation of a low anastomosis. However, after a rectal resection, these patients have a high risk of anastomotic leakage. This severe complication results in increased morbidity and mortality. Often, a reoperation will have to be carried out to treat the leak, during which a permanent stoma is frequently formed. Also, patients have a prolonged hospital stay, long rehabilitation times, increased long-term morbidity, and loss in quality of life. In an effort to prevent anastomotic leakage from happening, surgeons often cover the rectal anastomosis with a temporary loop ileostomy. Previous research has shown that a loop ileostomy reduces the risk of an anastomotic leakage, or at least reduces the severity of the anastomotic leak if it occurs. However, a loop ileostomy by itself is also associated with morbidity. For example, it can lead to dehydration and renal failure in case of a high output stoma, something especially seen frequently in warmer climates. In addition, a temporary stoma requires a second operation for reversal, and incisional hernia at the old stoma site frequently develops. There is much debate when a temporary ileostomy should be formed and when it can be avoided. Particularly, current practice in Australia and New Zealand is unknown. In Australia and New Zealand, data of colorectal cancer patients are recorded in the Binational Colorectal Cancer Audit, the BCCA. The BCCA is a database for clinical auditing, established in 2007. The aim of our study was to investigate current practice in Australia and New Zealand for loop ileostomy formation to cover the anastomosis after rectal cancer surgery using the BCCA data. We compared the characteristics and outcomes of patients receiving a stoma to those who did not. Data recorded in the BCCA between 2007 and 2019 were used. All patients who underwent a rectal resection for cancer with the formation of an anastomosis were included. A low anterior resection was defined as a resection of the upper 2/3 of the rectum, and an ultra-low anterior resection, which is common terminology in Australia and New Zealand, as a tumor in the lower 1/3 of the rectum. Patients were then divided into two groups, those who received the diverting ileostomy and those without a stoma. Univariate analysis was conducted. Continuous variables were analyzed with the Mann with NIU test or student t-test, and categorical variables were analyzed with the chi-square test or Fisher exact test. In order to achieve two comparable cohorts, propensity score matching was performed with the following covariates. In total, 2,900 patients who had rectal cancer surgery with formation of an anastomosis were retrieved from the BCCA. 89% of the patients received a loop ileostomy after a rectal cancer resection. 319 or 11% did not receive a stoma. The stoma group consisted of more male patients. Age was similar between groups. The stoma group had lower tumors, had higher preoperative AJCC stage, and received more neoadjuvant therapy. The stoma group underwent more ultra-low anterior resections and had more open surgery. In case of minimally invasive procedures, conversion to open surgery was more frequent in the stoma group. Postoperatively, the rate of anastomotic leakages was similar in both groups. However, in case of an anastomotic leak, the no stoma group had to undergo a reoperation more frequently. The rate of overall surgical complication, on the other hand, was higher in the stoma group, as well as the incidence of postoperative ileus more specifically. The median length of stay was longer in the stoma group, and more patients with a stoma were readmitted within 30 days. Propensity score matching on gender, tumor site, clinical AJCC stage, neoadjuvant therapy, surgical entry, and procedure type yielded 208 equally matched patients in each group without differences in baseline characteristics. Again, no difference in anastomotic leak rate was found between the two groups. When an anastomotic leak occurred, patients without a stoma had to undergo reoperation more frequently, whereas the stoma group still suffered from more postoperative ileus and had a longer length of stay. This table demonstrates the stoma formation rate according to the risk factors for anastomotic leakage as we identified them in this study, shown in the previous slides: male gender, neoadjuvant therapy, and tumor in the lower rectum. The rate of constructed stomas increased from 63% in case of no risk factors to 97.8% in case of 3 risk factors. The results of the current study show that 89% of the patients in Australia and New Zealand receive a covering loop ileostomy after a rectal cancer resection. Reports from other Western countries have shown lower loop ileostomy rates on a national level. For instance, similar studies conducted in the Netherlands, the United Kingdom, and Germany found a loop ileostomy rate of respectively 67%, 66%, and as low as 32.3%. Still, these studies did not report a difference in leakage rate between stoma and no stoma patients. Propensity score matching showed that a defunctioning stoma does not prevent anastomotic leakage, as this rate was similar between groups. However, an ileostomy does diminish consequences of a leak, as stoma patients required a reoperation less often. Similar findings were reported by Fraus et al. The AL risk factors identified in this study are similar to those found in previous studies. Defunctioning stoma rates significantly increased with more AL risk factors present, which suggests that ANZ surgeons are well aware of these risk factors. Still, in case of nil risk factors present, 63% of the patients received a defunctioning loop ileostomy in Australia and New Zealand. Some limitations of this study have to be addressed. Firstly, entry into the BCCA was on a voluntary basis until 2018. This could have led to bias towards certain areas and institutions, and means that not all patients from Australia and New Zealand undergoing colorectal operations were included in the database. Secondly, some essential data points were not recorded well, meaning we could not include all patients in the analysis and had to upfront exclude these patients. Finally, long-term follow-up is not recorded in the BCCA, including data on the stomal reversal surgery and its complications. Still, the BCCA is a large binational audit that captures the current practice of colorectal surgery in Australia and New Zealand, and is therefore the most reliable source to analyze outcomes on in Australia and New Zealand. In conclusion, the majority of patients in Australia and New Zealand receive a defunctioning ileostomy after rectal cancer resections. The ileostomy rates are high compared to other Western countries, with similar reported anastomotic leakage rates. It is suggested that a defunctioning stoma does not prevent an anastomotic leak from occurring, but it does diminish its consequences. Thank you for your attention.